Good morning, everybody. I'm Dr. Karunya. I'm an associate professor from the Department of Radiology. Today, we are all going to discuss about pancreatic cysts. So, let me discuss a case first, and then I'll take you into the theory part. Okay. You can ask all your doubts by the end of the session. Thank you. Okay. So we had a female patient who is 53 years old, who had swelling and mild tenderness in the infraumbilical region. There was no history of abdominal pain or trauma. We had requested the patient to get an ultrasound done. So ultrasound findings were anterior abdominal wall defect and below the level of umbilicus with omentum as its content. So this is not our concern for this specific case. We also had a well-defined cystic lesion noted in the head of the pancreas, which was compressing the pancreatic duct and the CBD. So we were thinking in terms of a cystic neoplasm. Then we had asked the patient to get a CT done. This is a plain CT, the patient. You can see that we can see the liver, the gallbladder, the pancreas, bilateral kidneys. You can also see a small cystic region near the head of the pancreas. So we were suspecting a cystic neoplasm, for which we had asked the patient to undergo a contrast CT. We had checked for the urea creatinine levels and it was normal. Similar images in a lower cut. So coming to the arterial phase, all of you can see that there is a cystic lesion in the head of the pancreas here. You can also see there's a light or a small septum in the lesion. So coming to the portal phase, you can again see the septum. You can see that this lesion is quite big enough. It is compressing the CBD and the pancreatic duct. See, you can beautifully see the septum here in venous phase. There are no other obvious abnormalities that contributing to this pain or swelling that she has. So let's see. So now coming to the CT report, we had given it as a well-defined non-enhancing cystic lesion seen in the head of the pancreas. There was no significant peripancreatic inflammation or fat standing. There was no evidence of calcification, solid components seen within the lesion, and obviously no communication with the pancreatic duct. Okay, so coming to the differentials of cystic lesions of pancreas, we only have a few cystic lesions, and in case of a pancreatic cystic lesion, it is we can identify anything on imaging. Maximum 99% of the cases we can identify it on imaging. Considering the other lesions, you would need a HPE correlation, but somehow pancreatic lesions, we will be good enough with imaging alone. So coming to the differentials, you have the pancreatic pseudocyst, mucinous cystic neoplasm of pancreas, serous cystadenoma of pancreas, intraductal papillary mucinous tumor, or you can call it IPNM of pancreas. So I have written just a hint here, that is this IPMN. It communicates with the pancreatic ducts. So you can also categorize it into the following groups. Coming to the pseudocyst. Pseudocyst is the most common cystic neoplasm that you encounter on a daily basis. especially in patients with chronic pancreatic pathologies or alcoholic patients. You usually tend to see a pancreatic pseudocyst. Then the other common lesions are intraductal papillary mucinous neoplasm, serous cystic neoplasm, mucinous cystic neoplasm. Coming to the, you cannot say it is uncommon. It is not as common as the other lesions. So these are solid pseudopapillary epithelial neoplasm, cystic degeneration of adenocarcinoma. This is a neuroendocrine tumor. Okay. So, since there are a lot of cystic lesions, I'll try and, help you with a systematic approach where you can, try step by step and identify if it is just a pseudocyst or a cystic neoplasm. Okay. Coming to this, see, in a pseudocyst, as I've already told you, you have to think of pseudocyst when you are dealing in a patient with pancreatitis, alcohol abuse, or any calculus conditions, abdominal trauma, or if you see a unilocular cystic lesion. Unilocular means just a single locule, no septums or no fibrin, nothing, just one single cystic lesion. Sometimes it may contain non-enhancing debris. Okay. So in these cases, you can think of a pancreatic pseudocyst. So first, as I told you, first history. Based on the history itself, you will have an idea. Then you come to the complaints and then imaging. Okay. Coming to the cystic neoplasm, think of the possibility of cystic neoplasm when there is no history of pancreatitis or trauma, or when the cyst has internal septa, as we have seen in this case, a solid component or a central scar, or sometimes a wall calcification also can give you a hint that you're dealing with a cystic neoplasm. Okay. So coming to the pancreatic pseudocyst, it is a unilocular cyst without any solid components, central scar, or calcification in most of the cases. The collection of a pancreatic pseudocyst is pancreatic enzymes, blood, or necrotic tissue. The debris within a cystic lesion is a specific MRI finding. Okay. So, history of pancreatitis or abdominal trauma is essential in this case. Cysts develop in 4 to 6 weeks and usually decrease over time, sometimes enlarge or become infected. It is found in any parts of the pancreas. We can see it in head, body, or tail, or anywhere within the abdomen, or sometimes even within the chest. We have dealt with such cases also. This is a CT image. It shows a large cyst in the upper abdomen level. See, we can see the liver, the gallbladder here. So it is in the upper abdominal level. It is a large cyst in the upper abdomen in a patient who has a acute pancreatitis. How do we say acute pancreatitis? We can see that it's effusion here. There is pleural and ascites. Okay. So this is the patient of a acute pancreatitis, as that is what I've said. You can see this ascites here and pleural effusion. You can also see that usually the fluid, it does not enhance. So here you can see that the wall beautifully enhances. Okay, so pseudocyst has a enhancing wall. There is no septa, there is no calcification. It is a clear, simple case of a pancreatic pseudocyst. Okay. Now coming to an MRI, MRI also shows that dependent debris. See here, as we cannot see this debris mostly on CT because it doesn't enhance and it is all similar density. Whereas in an MR, you can differentiate the fluid and the debris. You can see that this is the vault of necrosis in a patient with a pseudocyst. Okay. This is a beautiful image which tells you about the pancreatic cysts. Okay. So, serous cyst adenoma, mucinous cyst adenoma, main duct IPMN, and side branch IPMN. We are clear with that. So, see how it appears. Okay. In an serous cyst adenoma is benign. It is a benign condition. It is 75 to 80%. It is present in women, and the presenting age group is somehow between 60 to 70 years. So we call this a grandma lesion. To help you remember, you can remember that serous cyst adenoma is a grandma lesion. How does it appear? It appears as a lobulated microcystic lesion with 18% central scar. Okay, with calcification. So, serous cyst adenoma is a benign lesion. It presents in women in an age group of 60 to 70 years. It is multilobulated. It is microcystic and has a central scar with calcification. Coming to mucinous cyst adenoma. Mucinous cyst adenoma has a malignant potential. This is very common in women. So let's say it is 99% prevalent in women in the age group of 40 to 50 years. So we call this mother lesion. So see, 60 to 70 is the grandma lesion, 40 to 50 years is the mother lesion. These lesions are macrocystic. It doesn't contain little small cyst. It has a large single cyst, usually one cyst. 25% of the cysts have peripheral calcification, and 95% of these lesions are present in the body and in the tail. Okay, so you cannot see such lesions. It's not that you cannot see, it is most commonly seen in the tail and the body. Coming to the main duct IPNM, it has a malignant potential. This is one of the few cystic lesions that is equal in men and women. You can see in both men and women. It is present in the age group of 60 to 80 years. These usually, you can see it as dilated pancreatic duct. Okay, I will explain this papilla boata later. Coming to this side branch IPNM, it is again malignant potential. Again, it is equal in, it is prevalently equal in men and women, same age group, 60 to 80 years. These appear as a bunch of grapes, and it is connected to the pancreatic duct. So just a reminder, solid pseudopapillary cyst is called as the daughter cyst. Mucinous cyst is the mother cyst. Serous cyst is the grandmother cyst. Okay. Coming to the serous cyst neoplasm, we have already seen that it is a benign tumor. It is a large tumor. It has a tendency to increase in size and has symptoms. Same. It is seen in grandma age group. Okay. So microcystic or honeycombed cyst with a central scar and calcifications. Here again a CT image which you can prominently see that this is a plane and this is a contrast image. You can see that there is a cystic lesion in the body of pancreas where you can see that there is a central calcification here. Whereas in a contrast, you can see that there is an enhancing septum here. You can see that there are enhancing septums in these lesions. So a lesion, cystic lesion, body of pancreas, enhancing septum, calcification. What do you all think? It is a macrocystic lesion in 10% and difficult to differentiate from pseudocyst and mucinous cyst neoplasm. So considering the lobulated surface, no communication between the cyst and the pancreatic duct. Again, we've seen that it is hypervascular enhancement is sometimes seen and can look like a cystic endocrine tumor. Growth rate of these tumors are more than 4 centimeter. They can go up to 20 mm in a year. Okay. See, this is a MRI T2 weighted image, which shows that it is both a CT and MR image. This is a contrast CT, where you can see that in a 51-year-old female, history of abdominal pain, there is a hyperdense lobulated lesion with central calcification in the head of the pancreas. Whereas in T2, you can see beautifully that it is multicystic with a low central signal, which is a scar with calcifications. Okay. Yeah. Coming to mucinous cystic neoplasm. We all know that it is a pre-malignant tumor. It may transfer into mucinous cyst adenocarcinoma. It is exclusively seen in women, typically mother. So a median age group of 40 to 50 years old. They are macrocystic lesions with thick septations and peripheral calcifications. These peripheral calcifications are seen in 25%. This finding allows you to make a specific diagnosis. This gives you a clue. Okay. Location, as we all know, that it is in the tail and the body of pancreas. Most of the symptomatic presenting with non-descriptive abdominal pain. Okay. So this is a CT image of a 32-year-old female with abdominal pain. You all can see that it is a contrast image. There is a large cystic lesion here. You may all think that it can be a pseudocyst. If it can be a pseudocyst, we are keeping the differentials open. You can also see that there is a big chunk of calcification here on the cyst wall. So it can be a pseudocyst or a intraductal papillary mucinous neoplasm. No. It can be a mucinous neoplasm. Okay. Coming to the intraductal papillary mucinous neoplasm, these are mucin producing tumors in main pancreatic duct or branch duct. The location is head of the pancreas or tail. The condition is it must have communication with the pancreatic duct. So the best modality will be MRCP. Okay. These can be multifocal. Main duct IPNM has an imaging feature distinct from the branch duct. The branch duct type can look like other cystic neoplasms. I've just made a chart so that you can understand the difference between the main duct and the branch duct. Coming to the main duct, it is either segments of the pancreatic duct or the entire duct is dilated. Okay. It is filled with low density mucin material. Okay. Overlying pancreatic parenchyma may be thinned. Solid mural or enhancing nodules are suggestive of malignant transformation and something that protrudes into the mucin filling ducts. Okay. Occasionally, mucinous materials can be seen to bulge out of the dilated ample of water. However, this is a very uncommon thing, but it is pathognomic of a main duct IPNM. Okay. Coming to the branch duct IPNM, majority of the glands are normal, except for a single or multiple side branches, demonstrating marked dilatation. The cystic mass-like appearance, which often mimics cystic tumors. Its appearance has been termed as a bunch of grapes. Okay. Microcystic variety has appearances similar to the serous cystic lesion. But again, Communication with the main pancreatic duct is the key to the diagnosis. Okay. See, contrast CT images often IPNM with dilated pancreatic duct. As you've seen that in the previous images, none of you could have appreciated this dilated duct that we are seeing in this second image here. So, considering this first image where you can see that a cystic lesion is seen in the head of the pancreas with a dilated duct, it is confirmed that it is an IPNM with ductal communication. Okay. But this communication can be appreciated only on an MRI. Better appreciated, yes. The CT shows a hypodense lesion in the head of a pancreas. The microcystic appearance has raised the possibility of a serous cystic neoplasm, although there is a calcified scar. So we'll have to do an MR. Coming to the MRCP, the cystic nature is better appreciated, and there is no, yes, there is a connection to the widened duct. See, you can see that the red arrow shows a cystic lesion here. You can see that in a CT, you cannot appreciate the dilated duct or anything. Whereas in an MR, you can see that the blue arrow depicts the dilated duct. Red arrow shows the cystic lesion. So this lesion has a communication with the widened pancreatic duct. So this is a T2 weighted image which demonstrated the multicystic lesions. You can see that there are little tiny cysts. It is not one single cyst that we have seen in the previous pictures. It is a multicystic lesion with a connection to the pancreatic duct. So this is a branch duct IPNMN. Okay. So again, this is a beautiful depiction. You can see that in an MR, you can see that multiple cysts, as you can see in this demonstration. Okay. Coming to the signs of malignancy, when the pancreatic duct measures more than 8 mm, or when there is a solid node in the duct, when the mass is seen around the pancreatic duct, or an enlarged polydocal cyst, okay, you can think of a malignant transformation. This is very important because it changes the course of treatment. Okay. So coming to our case, we saw a well-defined cystic lesion with eccentric septations. In view of age, the location, and possibility of macrolocular series cystadenoma to be considered. My other differentials would be solid pseudopapillary tumor of the pancreas, primary ductal pancreatic tumor with cystic degeneration, then cystic degeneration of islet cell tumors, which is insulinoma or glucogonoma. It can also be a cystic teratoma or a metastasis to the pancreas. Coming to the solo pseudopapillary tumor of the pancreas, it is mostly, as we've seen, that it is seen in the pancreatic tail. So it is usually a well encapsulated lesion with solid and cystic components. It can also have a hemorrhagic degeneration. Okay, as you can see that I've marked with an yellow arrows to show you the lesion here. Okay, following the contrast administration, enhancing solid areas are typically noted peripherally. You can see here that peripherally, you can see there are enhancing solid areas, whereas cystic spaces are usually more centrally located. Okay. Classically, this image, you can see that the center is hypodense. Okay. Calcification and enhancing solid areas may represent at the periphery of the mass. Okay. Coming to pancreatic metastasis, it is very uncommon or only found in very minority people. Okay. Findings are non-specific. This is typically well circumscribed mass, which is iso to hypo on normal pancreas CT. See, you cannot say that there is a mass lesion. So it is usually iso to hypo. Coming to heterogeneous enhancement will be present homogeneously for a smaller lesion and peripherally larger lesions presumably due to central necrosis. In general, the enhancement pattern resembles that of the primary tumor. Pancreatic ductal obstruction is common for head and body lesions. It also may be associated with the CBD obstruction and intrahepatic biliary dilatation. Okay. So the common places where you get which metastasize to the pancreas are renal cell carcinoma. It is the commonest. Melanoma, breast cancer, lung cancer, gastric cancer, and colorectal carcinoma. Uh, there are some associations where I would like to tell you. There are these pancreatic cysts. It occurs in association with von Hippel-Lindau syndrome, autosomal dominant polycystic kidney disease, where there will be cysts in the liver, pancreas, kidneys, so, and in cystic fibrosis. Okay. This is a small pancreas CT protocol, just for a brief slide. Okay. In contrast, the patient should drink water as a oral contrast in addition to water upon arrival to the department. Okay. Opacification and distension of the duodenum is very helpful because the head of the pancreas is around that. Okay. So 125 to 150 ml of IV contrast at 4 to 5 ml per second is recommended. Okay. The scanning method is try to scan the entire pancreas, but in case of an abdominal study, you usually start from the Ziffy. Okay. So entire pancreas in a single breath. That is very important to avoid any motion artifacts. Okay. Single breath hold for all the phases, venous, arterial. Okay. The non-contrast 5 mm with 2.5 recons from liver dome to iliac crus are done. Okay. Detailed arterial portal and delayed phases, I'll tell you. Coming to the arterial phase, it is 2.5 mm scan and it is reconstructed from the top to bottom of the liver at ideally obtained excellent hepatic arterial opacification with minimum contrast in the portal vein. Coming to the portal venous phase, it is a 5 mm delay at 80 seconds. Delay with 2.5 mm reconstructions. Scan the entire abdomen in this acquisition. Okay. Coming to the delayed is usually a 3-minute scan through the liver and the kidneys. Okay. So a simple last take home message. Okay. We will split it into 5. So it is the age and the gender, the location based on calcification, mural nodularity, and the duct communication. Coming to the age and gender, let's say the daughter lesion is SPEN, okay, SPEN. The mother lesion is mucinous cyst. The grandmother lesion is serous cyst adenoma. Location, head and neck for serous and side branch IMPN. Body and tail for mucinous cystic neoplasm. Calcification, it is peripheral for mucinous cystic neoplasm. Central in serous cyst adenoma. Mural nodularity enhancement will think of neoplasm. The duct communication, a narrow duct, favors IP and NEM. Thank you.